Welcome to the Listen Up podcast, where we explore hearing loss, communication, connections, and health.
Hi, Dr. Mark Sims here. I am the host of the Listen Up podcast, where I feature leaders in healthcare. This episode is brought to you by Listen Up Hearing Centers. I help patients to remain socially connected and independent by effectively treating their hearing loss. I am passionate about hearing loss because I lost my brother Robbie twice. I lost him first to hearing loss from radiation to his brain tumor, and then when he succumbed to complications from the treatment of his brain tumor. I'm an ear, nose, and throat doctor who only takes care of ears. I'm the E of ENT. I've treated over 10,000 patients with surgery and many more than that with hearing loss, and am passionate about treating their hearing loss well. I'm also the author of Listen Up, A Physician's Guide to Effectively Treating Your Hearing Loss. If you want to learn more about that in my practice, you can go to listenuphearing.com. That's listenuphearing.com. Today, I'm really excited about my guest. I have Dr. Ned Stolzberg. He is the medical director at the Hospice of the Valley since 2007, where he oversees clinical care. He has worked with both a team medical director and as a palliative care consultant in the hospital setting. After growing up in Boston area, Dr. Stolzberg attended the University of Texas, where he received a Bachelor's of Arts degree. He went on to graduate from medical school at the University of Massachusetts and his residency at Phoenix Baptist Hospital. And I'm excited to have him here. Thanks for coming on, Dr. Stolzberg.
Thanks, and appreciate your having me.
Yeah, tell me a little bit about your course. Like, I know you were in family medicine, family practice. How did you end up at Hospice of the Valley doing hospice care, which is a wonderful service? It's really an excellent thing people need.
Oh, thank you. It's a great place to work. My personal journey started off in family medicine, and I knew nothing of hospice or palliative medicine back when I was training, which was in the early 90s. And my residency program had a community medicine rotation, essentially. And as part of that, I was assigned to spend 3 days at one of Hospice of the Valley's inpatient units, which I, at the time, dreaded because I thought it was going to be just horrible and sad. And I found it to be quite the opposite. I actually found it to be very refreshing in terms of the approach that was taken to medicine, how happy and engaged and friendly the staff were. And even how patients and families, despite the challenges that they were facing, were reacting to the care that they were getting. And so I tucked that away in the back of my mind and launched into my career as a family physician. And then a few years later, had the occasion for my mother to need hospice care. And I got to see all of that from the patient perspective, and exactly what could be done. And she was cared for both at home and for a little while in one of the inpatient centers. And that kind of sealed my desire that this was the kind of medicine that I wanted to pursue. And so I started working part-time in hospice and liked it so much, I decided to go back and get additional board certification with hospice and palliative medicine, and kept on going, and now this is what I do as my career, and it's taken me in a lot of different directions, and all wonderful directions.
That's wonderful. I mean, I'm a board certified in neurotology, which I always say is a tongue twister. And most people in medicine don't know there is a board certification in that. I didn't, but confess you, I didn't know there was a board certification in hospice and palliative medicine. How long has that been around?
Well, palliative medicine, hospice has been around since the early 70s in the United States.
How about the certification?
The certification for palliative medicine is relatively new over the last 15 years or so. Palliative medicine itself is something of a newer field, just in the last 20-ish years, maybe. So yeah, the board certification and the extra training you can get is in the last 15 years.
Are there fellowships or residency positions?
There are actually.
Wow,
in fact, Phoenix is quite fortunate. We've Hospice of the Valley has been very involved in bringing education to the Phoenix area, and we've partnered with a number of the larger hospital systems in town. So we actually have 4 fellowships in the Phoenix area for palliative medicine physicians for adults, one pediatric palliative fellowship,
Wow.
and then one fellowship specifically for nurse practitioners who want to get additional certification as well.
That's
Uh,
great. Training future leaders and future providers is a really a wonderful thing. I mean, it's interesting how it's regional. I mean, I did my internship in Philadelphia, and so that was in 1989 to 1990, and nope, 1993 to 1994. That was college and medical school, 93 to 94, and DNR just came then. So it's amazing how there's geographical variability. Hospice was not really an option there, and I know people are catching up, but it sounds like historically, Phoenix has been on one of the more progressive ends of that type of care.
Yeah, I would say that's true. It is kind of interesting. We are one of the older hospices in the country, and we're actually one of the largest nonprofit hospices in the country. And I'd say the number of educational opportunities for folks wanting to pursue this type of care, I'm not sure it can be matched necessarily by another
Region.
city,
It sounds
given
like.
given how many opportunities there are here.
So, what's the history of like who founded the nonprofit? That's a interest. I mean,
Yeah,
um,
so yeah,
it's not
we
it's
have
not
a
something I would think like, hey, I'm going to start this nonprofit, and this is the one. But
so hospice actually originated in the United Kingdom in England, and there was a physician by the name of Cicely Saunders, who she started her career as a social worker actually, then
uh,
became a nurse, and then went to medical school. And she decided after seeing that folks were not getting adequate symptom relief, that she would dedicate her career towards trying to change, specifically for cancer patients at the
right.
time, better care for end of life. And so she started the very first hospice in the late 1960s. And there were a couple of fledgling hospices in the early 70s. I think the first one in the US was in Connecticut somewhere. The story here in Phoenix was there was a local minister who read a Reader's Digest article about the hospice in Connecticut and said, "We need that here."
Wow.
And he and two volunteer nurses started Hospice of the Valley in his garage. Um, and now, almost 45 years later, we have 1,500 employees, and we cover the entire valley, and we have probably 2,400 hospice patients and another 1,000 palliative care patients that we help to care for every day.
I think that, it's amazing in two places. It's amazing in just the hospice space, but it's also amazing that it reaffirms people like, look, if you want to change something, you can start very small, very basic, belts and suspenders, duct
Mhm.
tape, and put it together, and it can turn into something pretty amazing. That's an amazing legacy for the founders. That's pretty amazing.
And the incredible thing is, I mean, I've really I find that the work I'm doing is something of an oasis in medicine, in that virtually everyone you can run into around here is going to be nice and friendly and helpful, and unfortunately it's not always the case. And just we have wonderful longevity. The first nurse, the two volunteer nurses that helped start the agency are now retired. But
Well,
the
that's nice
very
to hear that they got a chance to retire.
we finally let him retire. But the first nurse that we hired, as an employed nurse, in the early 80s, is just about to retire in January. She's
Well,
been
that
with the
speaks to the
agency for
organization. Right.
42 or so years. So
Speaks to the organization. Somebody wants to stay there that long. That's pretty amazing. So, one of the areas of interest I have is hearing loss is associated with a higher incidence of dementia and memory problems. And so,
mhm.
at the end of that, if somebody's unfortunate to have that, they might end up in hospice or those types of things. So, I mean, tell me about what type of criteria people with those particular conditions are, what you do to assess them to bring them, if that is where they are in their stage of life. How does that happen?
Sure. So I'm glad you brought that up, because dementia and related illnesses is probably one of the fastest growing areas in hospice right now. So hospice started as primarily for cancer patients. And obviously, large percentages of our patients still have cancer, but probably about a third of our patients at any time that are on our service have dementia or something related to that, whether it's Alzheimer's or Lewy body or something else. And it's actually one of the more, challenging areas to prognosticate. People often ask me, how do we know when it's time and when someone should come on hospice? And there are a number of criteria that, if you want to look on the CMS Medicare website and get a little bleary-eyed, you can read page after page of detailed criteria. But a reasonable criteria that we tell community physicians to look at is, would you be surprised if this patient passed away in the next year? And it's called the surprise question. And if the answer to that is no, I wouldn't be surprised, then you might be getting into the neighborhood where that hospice conversation should go on. And specifically, things that might inform you of that are essentially global decline. And so we look for decline across many realms. What could a patient do 6 months or a year ago that they can't do now in terms of self-care, whether that's bathing or eating or dressing? Are they needing more assistance with those fundamental activities of living? Are they having challenges with continence, with ambulation and walking and getting around? Have they had recurrent infections or recurrent hospitalizations? Weight loss is a very significant marker because so many people with dementia will experience weight loss, poor appetite, wasting, and so forth. And so if you add up a few of those criteria, and they seem to all be progressing on a steady path, you probably have somebody that is going to qualify or at least potentially qualify for hospice.
Right. So that's part of the spectrum of dementia, where you're talking about the other health related effects as people get to the latter part of the dementia, correct?
Absolutely. And I think one of the things that, a lot of times with dementia or actually any either, end stage chronic disease and terminal disease, is that you don't really need to wait until the last week of life for someone to enter hospice care. We can certainly do wonderful work in those last few days, but patients will often miss out on a lot of good quality and family support by waiting, waiting till the very end. And
Right. So
so,
I think the philosophy you're trying to say is maybe we do less at the beginning, but it is an escalating care model where as the need escalates, so you don't have to wait till it's a desperate time where, you kind of calling in the proverbial fire company to come in and put out the fire. It's like when there's a low smolder and you can help get to when the fire's coming, I guess.
absolutely, that's a great analogy. And I mentioned my mom earlier. She was a cancer patient. She succumbed to lymphoma. But my father ended up as a hospice patient a few years later, and his disease progression. He had Parkinson's disease and had cognitive decline as part of that, as well as a potpourri of other ailments.
Polymedical problems, right? Multiple
Ab-
medical problems.
Absolutely, and he. My mom was on our hospice team, was on a hospice team for 6 weeks at the end of her life. My father was on hospice for 9 months, and it was a godsend. To be
That brings
honest
you
with
great
you.
peace of mind, right? So that's the other thing people don't realize, that hospice is not always just for the patient, it's also for the family to help them have some peace of mind with that transition that's coming, but
Mhm.
you're supporting them as well, right?
Oh yeah, 100%. And I'll tell you that as a physician, when you have a loved one who's sick, the pressure's kind of on.
Yes.
And I so much wanted to not really be my dad's doctor.
Yes,
I
son.
wanted to kind of be his son. And it was such a relief when he went on hospice. He actually improved a little bit.
Because he got
He
more immediate care, right?
he had more care that was coming to his home. The hospice physician sort of took over some things. He was deprescribed a lot. In other words, he was on 25 medicines before that got cut down to the 8 or so that were really making a difference for him. It was a tremendous relief to me to be able to sort of back away from that aspect of his care, and just be able to be with him and spend time and know that help was a phone call away if need be.
Yeah, no, that's really a great lesson. And what a large percentage of your patients have hearing loss, or is that part of the situation usually, or
Yeah, absolutely. I mean, especially in the a larger proportion of our patients are elderly. So just sort of with the natural progression of aging, many have hearing loss, but we do see that as a complicating factor with many of our patients, especially with dementia.
yeah,
And then even with patients where it's not clear, you know, how bad their dementia is, but they may have some challenges that are milder, but then they show behaviors which are troubling to their caregivers and family. And quite often it's related to distorted sensory input, whether that's poor vision, poor hearing. One of the things that we've put together is a dementia team. And so we have some specialists when folks are struggling with, and with what we call distressed behaviors, essentially. And so many times it's
will.
chalked up to, there's
And down.
sundowning or there's some that. And it's not uncommon for our team to go in and discover, they need a new hearing aid battery, and now they can hear you and understand better.
Right.
Or maybe they need a hearing aid or some kind of assistive device, or their glasses are broken. Simple things like that can make such a profound difference in someone's quality of life, even if they have just a few months, of life to live. Being able to hear, see, and understand the people and the world around them makes a huge difference.
Yeah, the way I think about it is they're treading water just to get through the day, right? They're using every extra capacity and they're right operating at the margin. And so one of those little things seemingly insignificant can really push them kind of over the edge in terms of function. And frankly, if you can't communicate with people, certainly people are typically combative when they can't express themselves or receive information to understand what's going on.
Absolutely. So, and it's fortunate that we have folks that we're able to send in and evaluate people who are struggling with dementia, and sort of get a sense in their home of what's the environment like, what are the sensory triggers that might be causing the difficulty. Are folks in pain? Are they having trouble hearing? Are they having trouble with, constipation or relieving themselves in any way? Are they under or overstimulated? And making impacts in their environment can really help impact how they do more globally,
Can I
and
get them as
reduce
my
the need for
primary
that.
care doctor?
I'm sorry?
I get them as my primary care doctor because, that's what people want all the time, right? Those types of.
That's right. Absolutely. We'll send the team right over,
No,
right
but I mean,
after.
it's hard. Like you're talking about that kind of comprehensive assessment that, is very challenging in the medical environment, right? On a
Mhm,
day-to-day basis when people are kind of, hustling through clinic, if you will.
mhm.
And so it's really taking the time to assess, which is really wonderful.
Yeah, and that's been a really rewarding aspect of this practice is it does give you time. The cases are challenging, but we do have the time typically to be able to really sit down and work through the cases. And the other really gratifying aspect is the team aspect of things, where so many times when I was in private practice, I would think only I had a social worker right here to help me figure this out,
Now you
because
do.
yeah, now I do. And a nurse who's good at wounds, which I'm not good at, and a chaplain to help when someone has spiritual needs. And it's really nice to be able to go in and see someone in their home, which is where really 95% of our care is done, um, and go in with all these other folks where I know I'm not on an island. I can do the part that I hopefully know how to do reasonably well and make my contribution, and know that these other folks and other disciplines are there to do their part as well, and patch the holes that I can't.
So is Hospice Valley denominational or non-denominational?
Non-denominational. We'll take care of anyone from, any background, any creed, whether you have ability to pay, not ability to pay. All comers are welcome. We have taken care of people from, on top of Camelback Mountain to people who live underneath a bridge. And we try to meet them wherever they are as best as we can. So.
Really wonderful organization. Hoping I don't need it in the near future.
No, hopefully it's not. I wish it was something that none of us would ever need, but
There
it's
is
a
an
great
inevitability to
resource
it.
for inevitably when it is needed. So
Yeah, no, having lost both of my parents, I think that, just circumstance didn't allow it for me personally, but having that softer landing where you have people around you supporting you is really wonderful.
absolutely, absolutely.
So this has been really great. Is there anything else you would want our viewers to know about Hospice of the Valley? I mean, we've covered a lot.
Well, I would just tell you that we have a number of programs outside of hospice, including palliative care, which is for patients that are, their disease hasn't progressed to the point where they may qualify, or they may be appropriately still pursuing some aggressive treatment.
Right.
We also have what's called supportive care for dementia, which is for folks with and caregivers who are helping their loved ones with earlier stages of dementia. So, if they may not be in the hospice realm yet, but there are still difficulties, we have our dementia educators and our dementia team can help folks with earlier and moderate stage dementias as well.
Do you guys do those evaluations, or is that a referral off of evaluation from others?
It can be a referral from the community. So we accept referrals from community physicians, and we accept referrals from family members who call in and say, help. And we'll go out and sort of assess, is this going to be the right program for you? It's free of charge. We have wonderful community support through some grants to be able to offer that. And so access is very easy and very simple.
Yeah, it's fascinating when you look at the spectrum of hearing loss. That's why I was just asking about it. As it gets worse, the fundamental threat that hearing loss is to people with a progressive hearing loss is a threat to their independence, right? And
Mhm.
so the real mindset of it all is oh, I went to see mom or dad, and they're just not quite with it, right?
Mhm.
And it is interesting how hearing plays such a role, right? Like if you can't if you can't hear the question, or you're answering the wrong question, even if you're actually with it, people don't think you're with it. So it must be that's kind of right where you guys are on the edge of the hearing loss, causing these types of social disconnections that lead to loss of independence.
Absolutely. And then the other thing that I like to tout about our service is it's 24/7.
Right.
And that, if you call us at 2 in the morning because you're on service and you're in pain, you will get a nurse on the line at 2 in the morning. And if you need a visit at your home, someone's going to come out and see you. And
That's
so
wonderful.
it's a wonderful safety net for folks where they don't have to keep going to the emergency room, or when they don't want to, but they can still have their needs addressed, quickly where they are and when they need it. So
Yeah. As you're saying this, is there any estimate of utilization? In other words, what percentage of patients I mean, look, some people have sudden death, so they don't
mhm.
need hospice, right? Obviously, right? You can't call hospice when somebody's having a heart attack. But, what is the percentage of utilization of hospice versus the potential patient population that could benefit from hospice? That's kind of an interesting question.
Yeah, it is underutilized, and I don't have the exact statistics
What's your
top of
gut?
mind.
You're out there, man.
Yeah, I would tell you that we could probably we could probably take almost 40 or 50% more of folks with late stage chronic illness heart failure patients, COPD patients, and so forth, that we could actually help out. And when you look at national trends, adoption of hospice has gradually ramped up over the last, 20 or 30 years, but probably is still at about half capacity of really what could be reasonable. And some of it's education, and some of it is, just different philosophies of care. And, some of it is the medical system is challenging and can get disjointed. And I think hospice has to be is something where if you have, good ongoing care, from, your primary care team and your specialty care team, that's consistent, and it gets recognized that, oh yeah, this is someone who could benefit. But, sometimes people are in different hospitals and seen by different doctors, and they move from plan to plan or whatever. And I think that
disjointed care is a big
that becomes challenging in terms of people, becoming aware of sort of the trajectory of their care and the bigger picture. So.
Yeah, well, unfortunately, as you know as well as I do, that resonates everywhere in the care model, right?
Absolutely.
People showing up and you don't have their records, or that and just any sorts of results. So, well, I have to say this is really wonderful work, and I appreciate you doing this work on behalf of patients who really need, and you're really hitting a need in a time of life where it's super beneficial. It must be great to go to work every day.
Yeah, no, it's a great job, and I still feel the same way from that first day in 1993 when I had wow, this isn't depressing at all. This is actually bringing people a lot of hope.
Well, I mean, it's an inevitability. It might as be done with dignity and comfort and some sense of perhaps celebration, right? I mean, that's really what you want, is not celebrating the end result, but the celebration of the process and the life that is being brought to a kind end.
Absolutely.
So there's a question I ask everybody. I always ask everybody, since it is Listen Up, I ask people, what's your favorite sound?
Favorite sound? I'm a fan of the band They Might Be Giants. So the They Might Be Giants song would be my favorite sound.
Okay. This has been a great conversation. Ned, if people want to get a hold of you, how do they get a hold of you?
You can call Hospice of the Valley at 602-530-6900. And if someone asks for me, I will be tracked down, and they'll get me a message, and I'll get back to whomever needs information.
Oh, this has been great. This is for everybody. It's Dr. Ned Stolzberg. He is the medical director of Hospice of the Valley. Thank you so much for coming on the show. This has been a great episode. I really appreciate your knowledge and your compassion for patients in this stage of life.
Thank you so much for having me. Have great holidays.
Thanks for tuning in to the Listen Up podcast. We'll see you again next time, and be sure to click subscribe to get updates on future episodes.